Okay. Welcome to the team. We are honored and privileged today that Dr. de Haan is going to teach us from the Victoria team regarding orthopedics principles and management. So the next 2 weeks is dedicated to orthopedics. And it's the Vic team that will be teaching us. Today's session, we are trying to incorporate some practical work. So please bear with Dr. de Haan as we are going to try and make the most of it. I'm sure you will all catch quite a few pearls and wisdom from him, apart from the book know-how and the journals that we can all read. Welcome, Seb. The floor is yours.
Thanks, Scotty. Thanks for inviting us to do this session. And yeah, it's a pleasure and a privilege for us as well to do it. And yeah, try and offer some personal insight and any practical pearls and info to you. I've decided to also try and bring in a bit of a practical element to this whole process, as orthopedics is also very much a practical sort of application as well, or the management thereof of orthopedic problems. So it's a bit of a learning exercise, especially doing it in this kind of capacity in a virtual reality sort of setup. So apologize if there are hiccups. Please shout if you can't see or understand what's going on. But I'll try my best. Also, just with regards to the talk, Paul and Flip will be doing next week. Flip sends his apologies. He's in a meeting as well. And then Paul's also going to be doing hands, adult orthopedic hand injuries, and then Flip will be doing pediatrics. I'm going to be doing practical solutions to impractical problems, which will be some practical back slab applications to sort of offer some pearls and tips from my side, and then also doing back pain. So why did that topic come up? Well, I'll share with you. I'll be chopping and changing between the desktop and myself. Here is the PowerPoint. Oops. And let me just go back a little bit. So practical solutions for impractical problems. Obviously, it's impractical for the patient to have an injury or orthopedic problem, and we want to try and help them to achieve the best outcome. And this is why I want to introduce my sort of approach to managing the EC and as a theory or concept. So PPE for PPO, so positive practice environment, that is with the staff, and systems, and making sure that they're as optimum as can be to achieve positive practice outcomes for your patient, for yourself, for your nursing staff, for everyone involved in the EC and in achieving a best outcome for your patient. Then 5 key points. I actually approached our orthopedics specialist here, Dr. Jeannie McCall. What are some key aspects of orthopedic problems or pearls that she feels that we could perhaps do better or maybe understand more? And she gave me some tips here that I would like to share with you. That one thing she did say is you do generally do the reductions relatively well, but application of pop and splint application perhaps can be done a bit better. The other thing is ensuring that the master's is put on appropriately. Understanding back pain red flags. Does actually red flags really matter? Reduction directions on x-ray. I'm not going to be able to achieve that today, but that's just something that you need to put in the back of your mind. That's how you're going to be reducing fractures. And hands are important to do a proper neuro exam and document clearly, understand tendon injuries, FDF and FDP problems and injuries thereof, and cervical versus peripheral distribution of neuropathy there. And Paul, I don't know what his actual core topics will be on the hands, but this is just some feedback from the orthopod, Dr. Jeannie McCall, to you, some key points on adult orthopedics. So this is our pop room at Victoria Hospital a few weeks ago, And look, it looks like a teenage bedroom, but just with lots of plaster. So this is not the ideal environment to be applying plaster, or sort of how to do it in a way to create a positive practice and outcome and environment for yourself and for the patient. And just to sort of highlight, try and achieve a good outcome with, creating a clean space. It's professional, and all the stuff gets tidied up, ready for the next person and the next patient, whoever is going to come into your unit. So you have a responsibility to do this as senior clinicians, and you'll be running your unit one day or be involved in that whole process and ensure that that's done well. So this is just more of the room that was quite poorly looked after that. This is another emergency unit, and this actually is in Australia, but it's also representative of a unit that I worked in actually in Bristol in the UK that had a very profound and positive impact on my care for patients in having orthopedic problems. I want to highlight, this is the laser pointer. On the back of that room, on the wall, there are these posters, and then there are these templates here. And on the posters on the wall and the templates represent fracture injuries. So if this is a metacarpal box of fracture here, and that's the cast or splint back slab that you'll be applying. And this is one of them. I'll show you a bit more until I can actually see your screen and know what I'm doing. And this is the template that you'll be putting against the actual plaster of Paris. And for that one, this is for thumb spiker for scaphoid fracture as well, and proximal thumb injuries, and Colles fracture that's undisplaced, and the template thereof. The reason I'm telling you this, and I wanted to share these practical pearls, is you don't have to have a new back slab that's a whole new different design and process for every single patient that comes in with an orthopedic problem, depending on every single type of MO or registrar or any clinician that works in your unit, and it becomes a complete sort of free-for-all. Here you have a far more standardized approach. You can understand what the applications are going to be, and they'll be more adherent to certain processes and policies, and the outcomes hopefully would be achieved are a lot better. Also involving your plaster tech to do this whole process, and speaking to your orthopods so that everyone's on board, and then also creating a positive practice environment whereby people are proud of what they do and how they do it, and the patient's also very happy too. Okay, this also is a good site where this comes from. Life in the Fast Lane, a better way to get plastered, although I'm sure some people were imbibing a few other items and things like that. So that's how they got plastered, but this for plaster Paris. Charnley slab for Colles fracture that's undisplaced or minimally displaced. I use it quite a lot. This is my main go-to. I have a slightly different way of doing this, and I would hopefully want to try and see if I can actually show you. But 10 years ago, when I was in Bristol in the UK, I had worked with this plaster tech, and it changed my practice forever. This is how I standardize my approach to Colles and how I apply the actual plaster, but it's relatively similar. And the other thing I want you to notice on this actual poster is the way the sling is. So I was talking to our plaster tech, Marlon Mitchell, and he said one thing we don't also do very well is we don't actually bring the sling up high or apply it so that the actual arm should be much higher. And actually sort of probably less than 90-degree angle at the elbow, so that actually the swelling will drain down, and you get a better outcome that way as well. Tell me if this is working or not. I don't know. It's the first time I've done this. Studies. So this is dorsal splint or complete cast during the first 10 days, and they found actually the dorsal splint worked really well. No inferior outcome to that, and this I think is very important for you as clinicians going forward, and you'll be managing units and managing people in order to achieve a positive outcome for your patient. Okay. So this is the Colles fracture, and I'm going to hold on. Okay, you're not going to see that anymore. And what I want to show you, that Colles fracture, I don't know if I went too quickly on that. The other thing with X-rays is knowing, how to interpret it, what to say, and how to convey it well verbally, as well as writing it down, and then knowing what you're looking at. So that's important. Those are skills that you should be learning in your units or have already learned and brushing up on. But that's important. And can you see this? Okay, so this is a template of that Charnley back slab, and the reason I'm showing you is you can use this in your unit and create these sort of templates. This is for Colles. This is for the scaphoid thumb spiker, okay, and volar slab for like metacarpal. I'm over here. Metacarpal fractures like a boxer fracture, okay, and this can become your standard in your EC to alleviate any deviation, which then also results in sort of varied outcomes for the patients that you're going to be seeing and managing or overseeing. That works really well, and I think creating that sort of standard approach is excellent. Then this is a bit difficult to convey, but am I still okay here? Can you, hold on, I actually don't even know if I'm still on or off.
You're on, Seb, we can see you.
Fine, okay. So, this becomes a little bit more challenging, okay. But one of the most important things, as I said, you can do, it's a better way to approach this whole sort of aspect of back slab. As I said, Dr. Jeannie McCall thinks we can do this better. Communicate with your patient, communicate with your staff. May sound obvious, but it's not so obvious for the patient what you're going to be doing. So important to do that as well. And then the other thing, as I said, how you're going to be managing this afterwards and what you're going to be doing, and with some pearls there. So you're going to be using this, I'll probably sit down. Solvance product. One of the things I'm going to show you just from a practical pearls point of view, how often, you can see my hand here, when you put your back slab on, do you actually stop at the palmar crease? So if you aren't stopping at the palmar crease or you're going beyond that, that's too far for the Colles that I'm suggesting you how you apply it, okay? So very important that you apply that correctly so that the hand can move appropriately and the thumb can move relative to that. And then the other thing is, stopping. Can you see all that? Ensure that the back slab, when it comes down, it actually sits 2 fingers distal to 2 fingers from the antecubital fossa. Okay. So that it also doesn't impinge when the person moves the arm. Okay, so that's important. Okay, these are 2 sort of important pearls that you probably have learned, may have done it, but at 2 in the morning when you're applying CAS, or you expect your juniors to apply them well, or whoever you're overseeing, whether this should be done without really much air to that. Okay, so that's important. And then the reason I'm just going to show you just very quickly how I do my Charnley slab for Colles. Okay, so mine's slightly different, and I'm not going to do the CAS too much because actually realizing it's going to be a bit more challenging with me on my own and no support or help. But as I said, measure from the palmar crease down to the elbow here. I'm just going to do a couple, and you're going to be doing with this back slab. Actually, often people cheat and don't put enough on. So using at least 2 15mm two 15 millimeter or 150 millimeters or versus 15 centimeter gypsona plaster Paris. It's quite wide, and the reason for that is I'll show you now. This is torn. Okay, and then every self-respecting emergency physician should have a good pair of shears, all right, and know how to use them. I hope you all do, all right. So, and for cutting for the right hand and the thumb and a hole for the thumb, we're going to be cutting a hole here. Okay, can you see all that? Can you see that? And may need a bit of space. So if you can see all that, the reason I'm just showing you this changed my life the way for practical application of a back slab for a Colles fracture. So first of all, what I want you to do when you're going to be disimpacting the bones that have crunched together, you're going to be uncrunching them if there's such a thing. But you're going to be applying some distraction force. There's going to be a force factor distraction. You're going to grab the thumb. And what many people do, which is done poorly, is they think they need to be strong and muscular and make it happen. That doesn't really work so well here. You can be petite and slim and slight, but using your body physics. So when you do it, I want you to pretend you're windsurfing and you grab the person's arm like this on their thumb or their hand like that, and you just lean back with your body weight. And you do that for at least 4 minutes, or at least. And then you have someone who's applying a bit of counter traction at the elbow. But you don't need to apply muscular force, you just use your body weight and lean back, and that should help apply some distraction to the bones that have actually impacted on each other. And creates it's a much better way of doing it, that you don't actually get all tired and distressed and feel like then suddenly you also need to start manipulating the wrist when it cannot be manipulated that well because you haven't disimpacted the impacted bone. Okay, so once you've done that and disimpacted it, then you've applied your felt band or soft cotton wool, etc. Then you do all of that. You don't need to put a hole in it, and you do your figure of 8. Then you measure your back slab from the palmar crease to at least 2 centimeters distal to the antecubital fossa. Okay, I'm not going to do that, but it's important at least 2 centimeters. You can even go a bit shorter. I often actually go probably even at least 3 or 4 fingers, depending on. And then what to do is, what happened there? Right.
We're still good. We can hear you. We can hear the demonstration.
Well, I've lost you completely. So, okay. Fine. Then, so, okay, I lost you on that screen, so I don't know what happened there. So you're doing that. You apply. You've got an impacted Colles, a radial fracture, who is dorsally tilted with some radial deviation. Okay, and it's impacted. So you've now distracted it. You're only deviated, and palm reflection. Okay, so you like that. The problem with some of these backstabs that people put on is they don't allow that sort of support here, and this is why I want you to see how this works really nicely. The backstab that comes on the side here and comes in the ear and doesn't sometimes always stop this sort of twist or reversal back to its fracture position. And this changed my life, or changed maybe hopefully the patients that I see. So this is what I do. This is the Charlie one that they've recommended. And you match this over this 15 centimeter and you cut it out. Okay, and you cut it to match. And then you apply it to the patient. I've changed mine slightly by not cutting all the way through, okay, with that slim little area. Okay, and this was taught to me by Plastic. So that creates a bit of a stability there and it doesn't flop over. And then when you slide it over the wrist and the hand and the thumb like this, oops, the other way, sorry. Then you can, what you do is you can then mold it. This can create a bit of more, you can rip it even if you need to create a bit of a bigger hole, and you mold it around, okay? Can you all see that? Mold it around, and it stabilizes that fracture site a bit better and stops the thumb from and the wrist from actually going back to a radial deviation dorsal tilt, because now you can actually mold the whole cast like this. That's a bit long. As I said, I should have measured it a bit better, but for sake of teaching there. So this is what you've got. You've got this cast that's applied right over your main fracture site, which would be the distal radius, and this splint backstab support that works wonderfully to support this whole broken bone. Okay, so that's what I do now, and I'm doing that for 10 years, and I haven't had really that much, or I haven't really known negative feedback, but I guess, but it has changed how I do it, and I've felt that also the patients were happy with that, and being able to actually get a better outcome. So that's for that one. Okay, so that's and that you can create a template like this, or you even do a template like I've done, or what I've shown you with on the back slab, and you create a template that'll fit that finger. The thumb spiker, okay, which is what this is as a template, and this also is very nice. Also 15 centimeter plaster Paris, and 6 to 8 layers, okay, and you can do colors to add a bit of vibrancy to your pop room, and also differentiation as a visual clue to which one you're using, okay. And then if you're going to be this plaster actually application is a bit more challenging in a Zoom sort of environment or a meetings environment. But let's say you've got a scaphoid fracture, where is it? Just here, or the first metacarpal is broken for some reason, and you need to support it. So measure this thumb spiker, okay, and you measure it and you apply it over the hand. Also a little bit of functional position, so a bit of dorsal flexion of the wrist, and then you wrap this little loose bit of the actual spiker splint around the thumb and around the wrist to stabilize the actual wrist and stabilizing thumb, and that's your thumb spiker. Okay, all these templates that I've done, I've sent you links to, and Lauren has the links, and it's also on that Life in the Fast Lane Get Plastered. All you need to do is look at them, PDF, print them if you want, and then that's voila, there you've got a template for you to practice with, and the more you get comfortable with it, the easier or better you become at it, so that there's a standard approach and also standard outcomes for all the patients that you're going to be seeing in that way. Same goes for, so this is what I do regularly as well. So patient with a box of fracture here, they've punched the wall like that, and now they've got a fracture in their thumb here. So and what you're going to be doing, measure it also. Again, 150 millimeter or 15 centimeter gypsona. Okay, this arch cutaway for the thumb, and you apply the back slab in this sort of position. Okay, functional position for the patient, and then they get good analgesia and able to follow up at fracture clinic with the orthopods. The other tip and pearl when you're applying back slab and you've applied it, and this is what the plastic tech Mitch mentioned, so you applied it, is your elastoform that you're going to be using, okay, for your back slab. The first one, and I've never done this really that often, to be honest, but it's something that I will do in the future going forwards, and I don't know how many of you do it, but you dip your first one that you're going to be using to fix the back slab against the patient's arm or leg in water first, because it also, by doing that, it sticks to the back slab and sticks to the plaster of Paris much better, so that it adheres initially and keeps things in place while you're applying it. Often you're applying these things on your own at 2 in the morning or whenever, but the challenge is actually you're doing a lot of things on your own just with the patient. Okay, where are we at? I'm going to now go back to my talk here, and I may have gone ahead or behind. I don't know what time frame we're at. Okay, so there's the collies impacted. Okay, so, and you can look at this. So when you describe this as well, important to describe this properly. And if you're not, don't have adequate views, then also ensure you get adequate views. So use correct language, impacted, radially deviated, dorsal tilts, angulation, etc. And there's some good sites for this. One of them is Learning Radiology, and you can go to that as well. Yeah. Then this is the scaphoid fracture right there. And I've already gone through that with you with the thumb spiker. And these are the metacarpal fractures that the patient sustained, and the use of the metacarpal volar slab. Okay, where are we at here now? So this is a fracture of the proximal humerus. Also, you need to know, is this the surgical neck or anatomical neck? The anatomical neck being up here, surgical neck being down here. And then how do you apply the support or back slab? So I'm going to apologize. We've done a great video of this, and this is part of also learning and trial and error from our side. I wanted to upload the videos and have a nice slick video. The problem is I've been having quite a lot of IT issues with the videos because iPhone and my computer don't always talk to each other very well. So how do I get out of here again? Okay. So the problem is I'll be sharing some of those with you. MIDI was very, very helpful in getting these videos sort of sorted. So, and yeah, they will be coming so that I can send them to you and you can learn from them as well and learn from our plaster tech. It's done a great little trick with the U-slab that I've never really used before. So I'm looking forward to sharing that with you. And that's one of them. And the other thing that if you don't, so the plaster tech used some of this collies or sort of sling, and what he did is he cut this sling and then stuck it to the patient's skin on the arm. Where are we at? And that covered over the clavicle, and you created a supportive area for the U-slab and the back slab. I know that's not very helpful for you to show you, but I want to show you that further. The other thing, the top tip with the U-slab that I also learned from an orthopod himself, if you're going to be measuring, I'll use this elastoform, and you're doing the U-slab, I want you to go, when you measure the U-slab, and this is what I think I'd still do, is you go right up past the top part of the ear, because invariably what you'll find with the U-slab is it'll slip and it slips down. And then what you do with that extra little bit, eventually that is left there, you create a little lip, like a surfing wave, whereby you can tie a strap around it. Okay, and that's very useful to help support the U-slab and stop it from sliding all the way down the arm. As I said, I apologize, I don't have more like a nice dynamic video for you to show, and also the guest or a guest sort of student to be able to do this with. Yeah. Then where are we at? I'll show you. Then the other thing, so that's myself with Mitch, Marlon Mitchell, and we just have a linen saver over my arm to help sort of protect myself just from all the plaster and stuff, so I don't get too messy. But you can see here he's put on that little foam on the shoulder or just about over my clavicle and shoulder area, and he's taped it down. I've actually never seen that before, taped to the skin. Concern I do have with that is the sort of contact dermatitis, pressure with that on the skin, or any sort of shear force from that. But he seems to think that that's okay. But it's just something for you to bear in mind if you do use this approach. Watch the space. That stuff will be coming to you. There are quite a few different videos. Ones will be below elbow, collies are below elbow, above elbow, U slab, below knee and above knee back slab. Okay. Also, what Mitch is showing here is that often these fractures are bent and sort of valgus or varus sort of angulation, and a sort of a valgus force here, and you're going to stress now a varus force or a banana shape, and you need to sort of it's bent out. Let me just go back to where we at here. So it's bent like maybe the humerus is bent a bit like this, and you need to create a sort of another shear force to straighten it out a bit. Okay, so and often it'll be fractured like this. Let's say if this is the right humerus, so you know how to sort of apply a shear force to straighten out the humerus and create that shape that you want with a more anatomical position. And then you put your U-slab down and around, high up into the axilla, and then down around the arm, come up and over, up, and the back side coming up to the ear, and then rolled over. Okay. Where are we at? Stop me if you're not following anything. There he's done it here, and I want you to see this is the strap now that goes around my chest. That he's now folded over this U-slab and created a little lip. He's now got the strapping that goes around, folded over, and it's now going onto the opposite side of the chest wall and tightens there. And the nice thing with this kind of strapping is it's soft and doesn't cause a lot of pressure or sort of pressure to the actual patient's chest. Okay, so now this is a Weber. Hopefully you'll be able to say what it is, but a Weber A fracture, and this you're going to be applying a below knee back slab. Okay, important here with the below knee back slab is important that you use enough plaster. Again, not too much, not too little, but enough, and important just that you're applying the back slab appropriately. Also, it's going to be, I'm going to back off here. Okay. I don't know if you can see all this. It's going to be a challenge. That's quite funny. Okay, let me see if I can actually show you. I was going to try and show you on my leg. Okay, got my shoe off anyway. My metatarsal heads are coming up here, and I don't think I'd ever thought I'd be taking my shoes off and sticking my feet in your faces. But anyway, so the back slab coming up to here, the elastoform, not the elastoform, the actual fell bunt cotton wool, and then down around the foot. And then you want to be 2 finger breadths at least, 2 or 3 finger breadths of width from the actual popliteal fossa on posteriorly, so that you actually have space for the cast when it does the back slab. When you bend your leg, that down. Okay, so you're going to do that. All right. So one thing that Mitch does mention is when you measure this, measure it with the cotton wool on your leg, and then all the way long. So measure your back slab. So you're going to be using the back slab and measure it such that you you don't go too far beyond either side, so it's not too long or too short either. Okay. Then where are we at? Sorry about this. Oops. And one of the things I did write in here, yeah, so wetting your elastoform back slab Dipsona. He said using at least for this, where are we at again? There. Oops, sorry about this. It's more practical issues. This kind of presentation. So what do you use? So important, I'm using 100 millimeter and 150 millimeter or 15 centimeter gypsona for this. Okay, and you're going to be using 4 rolls of the 150 4 rolls at least. Okay, 150 millimeter gypsona. And then you can be using 4 rolls of the 100 that you can place down the middle of it as well to support the provide extra integrity to the back slab. And then if you're going to be using a box slab, you're going to be using 2 rolls of the 100 millimeter gypsona around the side and coming around the side of the ankle as well. It's a pity I don't have this, and I apologize for a bit of IT dysfunction on my side, or at least the last few days of trying to get it together, and it, unfortunately IT is not agreeing with me. So sorry about that. It is coming. This fracture here requires an above knee back slab. Okay, so very important, and it's often the one that's done poorly as well. Often the actual back slab ends up just a few centimeters above the knee. That's not good enough. It should go all the way up into the groin. Okay, and it's important that
you are not sharing your slides anymore.
Am I not sharing my slides?
Yes.
Right. That's a problem. Okay. So right. Okay. So I've just spoken a little while and I haven't shared anything. That's fine. No problem. Okay. Can you see that?
Yes, I can. But you are not in presentation mode.
Okay. Can you see my notes at the bottom underneath, or do you just see the slide?
With the notes. You are not in presentation mode at the moment.
So you see my notes as well. So above knee box back slab, tib fib patella or tibial plateau fracture. Use 2. This is all from our plaster tech. So these are also just pearls and tips for you to do it. So instead of going in to do these back slabs willy-nilly and just sort of a thumb suck, you need to start practicing it well and doing it from a practical point of view. This is what I'm going to use, and this is my standard that I'm going to achieve, and this is going to be a constant, and do it well to the best of your ability rather than just
slop it on and not really worry about what is going to actually, its function or what it looks like as well. Have a bit of pride and trying to achieve the best outcome, as I said. Practice positive practice environment for a positive practice outcome. So a positive practice outcome for your patient and for yourself. Okay, so 250 millimeter underpanding, plus maybe another 100 millimeters, depending on the size of the patient and their leg. Use 4 times 200 millimeter gypsona. So this, so the 200 millimeter, which is one of the largest ones and widest, is very useful to wrap all the way around the back of the leg and come up either side. Okay, on the medial and lateral aspect for the back slab, plus 4 times 100 millimeter down the center of the back slab, as I mentioned. So I think I said 150 and 100, but you can use 200 and 150 for the back slab, then 2 to 3 150 millimeter gypsona for the side part. Then this is the other thing that I didn't do, which I'll change my practice a little bit. I've always put the back part on first and then the side on afterwards. I guess it probably doesn't really matter, but the nice thing about that is often the side ones can be a bit more challenging to hold in place versus putting it on, let it stick. You can even use some wet elastoform around it, and then you apply your back part onto it, use the wet elastoform on initially, and it sticks better to the back slab gypsona. And remember your foot at 90 degrees and the knee flexed approximately 5 to 10 degrees. Mold it into the shape of the leg, and you may also need to push quite high up. Okay, so can you see? Are you seeing it all? Stop sharing. Okay, so one of the things. So I don't know if you can see that, so make sure that the person's not like this, or your ankle's not. Go for gold and do it well. So get that foot up pointing 90 degrees, or the ankle 90 degrees, knee flex 5 to 10 degrees, and the back slab coming at least sort of halfway up the thigh. Okay, so you need to go quite high up into the groin and wrapped around and come down. This is often done poorly, and I know we can do it better, and I know all you can too. So don't be sloppy, and achieve a better outcome for your patient, and also for achieving a better outcome so that some patients may not even need surgery because you've done such a good job on reducing that fracture with a good close reduction. I'm going to go back to this picture, which I want to show you. So here, let me just click on it. Sorry, I'm just going through it all again. Okay, can you see that? Hello? Anyone out there?
Yes, Seb, we can see it.
Okay, so this was put on by, for hypothetical sake, one of the Regs, or EM Regs, or MOs. They've done a reasonable reduction, but not good enough. And one of the reasons I say that is if you look here, that talar shift is still a bit too much. And so it's still laterally deviated or laterally shifted, and then also posteriorly here as well. So we would want a better reduction than that, and I know you all can achieve that. So what you need to do is apply force and counter traction to achieve this. And you can see also there's a little bit of molding going on, but not too much, and we can all do a better job on that. So this is what Mitch or Marlon Mitchell has done, and you can see a little bit better job. He also noted, and he admits, look, he could have done a better job of placing that ankle in 90 degrees, so there's a bit better dorsal flexion there of that ankle. But you can see a better angulation of molding of this ankle here, so that the approximation back into a more anatomical position
is achieved, which then results in the patient not needing an ORIF or any surgery, which also mitigates all those complications and problems. And this person can achieve a good outcome just with this closed reduction. And you can do that. I know the swelling can sometimes be a problem, but this is the other thing that I want you to have a good verbal spiel when you're done. So what do you tell the patient when you're done? So we've all heard don't stick needles and things like that on the back slab of the cast, et cetera, et cetera. But have a standard approach to all your patients that you discharge from the EC. And I use the acronym. You don't always necessarily need to like acronyms and anything else, but once you start getting developing, you don't even think about it. So when you're going to be discharging that patient, you're going to be discharging that patient home. And home stands for H for health advocacy. And the reason I'm mentioning this is for people also studying and doing exams. And this is just a pearl for the exam. So when you are doing exams, I get spotlight paralysis and freeze sometimes, or that side of your brain goes to mush and you're not really achieving all the best you can. So you need to unlock that, that process of freezing to achieve a better outcome for yourself. And these kind of things do help. So when I discharge a patient, I discharge them home, and a health advocacy to teach them about the fracture, teach them about the possible complications, etc., so they understand it. And if they need anything to go look online, like Google, then give them a site that you trust and use. And one of the things that I use to trust in my practice on a daily basis is I use patientinfo.co.uk. It's a great site from the UK, good layman's words and terms, and people and the patients can actually go to achieve that. The other thing is I have a separate email. So these are all just tips that aren't for your book studying and stuff, but this is a practical tip. I've created a separate email that is a one-way email. So just Dr. Seb de Haan at yahoo.com. And I then link info to that to then email to the patient. It's on that a disclaimer. Don't use it for any feedback or reply. You're not going to get it. But I can then actually feed info to patients, because as we become more tech savvy and our patients also become more tech savvy, you can do that. So, and it's actually very well appreciated, because then they can go home and they can sit in their own time and read, okay, and learn about whatever problem that you've told them that they've forgotten because they're too freaked out that you told them that their leg is about to fall off, and that's all they hear, and they stop hearing anything else. So come up with practice tips for yourself, but those are a couple of them for myself to you that I use on a daily basis. Okay, so don't get scared of Google and use it to your advantage in that way. So as I said, health advocacy. Oh, for outpatient follow-up. So organize that for your patient and get that done. And then M for medication, get your patient's medication as needed, analgesia, etc., all of that. And then E, H-O-M-E, to explain to the patient when they should come back or what they should look out for to ensure that they don't just sit at home and watch their toes turn blue and their foot becomes numb and they're still sitting looking at it, rather than tell them to come back if there are any potential complications that you need to advise them regarding back slab or cast application. So that's my little tip from that side. Okay. Well, I think that's it on my side on that. Any questions from a practical point of view? And I'm sorry it may not have worked out. I really wanted it to work out a bit better, but I found that this sort of stuff really does work on a daily basis for changing the way you practice. And my colleague's application as well has revolutionized my life. So, yeah, Emily, how do you raise your hand? How does this work?
Hi, Seb. Yes, I did. I just have a question. Thanks so much for your talk. And I really think the templates are helpful. Oh, hi. I just wanted to ask, in terms of, you were just mentioning the valgus and varus deformities in terms of your humeral shaft fractures. You're just, sorry, they're drilling in the background. But you mentioned something about having to correct it. Can you just clarify it? I missed that part because I thought the whole point of the use lab was that gravity would come into play and correct the angulation deformity on its own.
Yeah. So thanks, Emily. Yeah, so the combination of the two, you can the whole sort of force of it and the weight of it, holding down, I guess maybe like that, to weight it, and it'll does correct on your own, but not as much as I think that sometimes we think it will. And you can also, with a bit of gentle application of force and with a varus or valgus force, depending on whether it's or angulated sort of inwards or outwards, and I know I'm not using the technical words correctly there, but you can apply a bit of gentle force either towards or abduction or adduction on the distal aspect of that actual fractured humerus to get some gentle straightening. You can help facilitate that, so you don't have to just all wait based on the weight of the actual use lab. So what you can do is just with this force here, let's say, where is it? Let's say, for example, this is a fracture and it's bent like that. You can apply just with also verbal encouragement with the patient, apply a bit of gentle force. It can be a bit sore and painful, but with gentle encouragement, you can also achieve that too. So, and it's you can then help facilitate a positive result there.
Thanks so much, Seb.
Pleasure. Yeah. Hi. I can't. Hi, I can't hear you. Can you hear me? Where am I?
Can you hear me now?
Yeah.
Yeah. Perfect. Yep. Long time no see.
Yeah.
Very good lecture. Many handy tips. I will poach many of them, if you don't mind. Only one question. If you reduce a fracture, do you always confirm positioning with a check post-procedural x-ray, or do you use any other devices?
Yeah, so good question. And I think with your expertise in ultrasound, you understand that that's also being utilized a lot in the EC, and we do use it actually. And I think there's a lot to be said for that. So I've used it as a sort of a dynamic process, whereby if you're going to be, let's say you have a fractured colleague here, that you can slide the ultrasound probe over it, look for the actual break in the cortex and the step in the deviation, and then apply the distal force, and then apply the ultrasound probe on again. So while you actually so you need a bit more hands to do that, though. That's all.
Yes.
So that you apply, so you don't, especially one that's perhaps not so unstable.
Yeah. I think the only two fractures that you would probably use it for, or conditions, would be Colles fracture, as you said, and you would do a pre and a post. And the beautiful thing is you can actually, this is self-taught, so you can teach yourself, and then you can check with the check x-ray afterwards how accurate you are with your ultrasound assessment. So, which is beautiful. And then the other application will be anterior shoulder dislocation and reduction. So I think if you use it in those two applications, you will avoid many unnecessary redo of cost when you need to reduce it due to inadequate position. So it's something that everybody can self-taught. I mean, you don't need a course for it.
Yeah, I agree with you, Hein, on that, and we do use it, and perhaps we could use it even more as you become more comfortable with just like any tool or procedure. The better you get it, and more familiar you become with it. But it's wonderful because we've all been sort of sat there thinking, well, I don't have a C-arm, but you've actually got an ultrasound probe in your hand. So you've got a dynamic device, a tool that you can use to which will create a better outcome.
Yeah, and another question: how do you reduce the Colles fractures? Do you do hematoma blocks, or do you sedate the patients, or?
Yeah, look, I used to use a lot more hematoma blocks, to be honest, and I think that they do work well actually. But the problem I found with them is the teaching of how to do it well. And I think that's not always, sometimes we do it, and I think a lot of us, just as we do, we learn, we don't necessarily raise our hands up, or we go to the actual anaesthetist or the orthopods who may have done it well and get proper teaching from them. So we kind of do it by trial and error ourselves, and we don't often get a good outcome, and then we get frustrated with it. So, but what I have found is that it does need to be properly into the hematoma or into that fracture site area, and the local needs to be put into that correct position. Otherwise, you may not get the results you need.
Have you tried ultrasound for that as well?
To be honest, I haven't, and that's a good point.
It works extremely well. But it's difficult to do it real time. So you map out before you go, so you can actually see the hematoma, you can see the fracture site, and you can actually deter the angulation. And then you make the marking on the skin, and then you go in. And then your probe is there to do the pre and the post reduction check as well. So you leave the gel on, and you do it afterwards as well. So that's something that's also self-taught. So try it next time.
I'll definitely use that. That's a great tip. Thanks, Hein.
Thanks.
The other thing is, so probably otherwise procedural sedation and using a lot of that. Actually.
We're using both.
The one thing I did use in the UK, which we don't use so much here, is using, what do we use? Prilocaine, I think.
Yeah, BS block.
That is great. Yeah, we use the BS block, the Prilocaine, and actually, what's that? Yeah.
It takes an hour.
Yeah. So there's a lot of other aspects that come with some aspects with that. Yeah.
Okay. Perfect, man. Thank you.
Thanks, Hein. Who else is here? I don't know, how does this, so you're raising your hand. Cameron?
Hi, Seb, can you hear me?
Yeah.
Hi, yeah, thanks for the talk. I mean, it's a very, basically you gave us like a YouTube lecture, which was quite cool. I think it's something we can build on, and we can really use this kind of format. So thanks for piloting it for us. I just got two things I wanted to say. So I wanted to ask the collies reduction in particular. So since internship, and I've seen and been taught by as many orthopods that I've come into contact as many ways to reduce and hold the reduction of a collies fracture. But the one thing that I look for, and I just wanted to know, it's quite tricky for me, is with a specific semiflexion and ulnar deviation that we are taught, it's very difficult to get the functional position of the wrist correctly. So you might reduce the fracture, but 3 weeks down the line, they lose functionality of the grip strength in their hands. And they make the classic distinction of, if people use their fingers, if they're a piano player or whatever, and they have more dexterity in their fingers, they can be lost if you do not preserve that functional position of the wrist better. So that was the one thing I just wanted to know if you could maybe just go through that a little bit again. Sort of this position is, I don't know if you can even see, it looks a bit weird here. This kind of ulnar deviation doesn't really lend itself to that grip. And then the second thing is just a comment on the ultrasound stuff. So for the other registrars, anyone rotating through Red Cross Trauma, it's a great place to learn, because you're by yourself most of the time with very nice senior orthopods. And that particular use of the C-arm, so we did a few when we were there, so 4 arm fractures. Because the kids are small, it's easy. You can get the ultrasound from next door if they have the one in trauma working. Put the probe on, you can actually see the actual radius fracture. While when your colleagues are reducing it, you can see the bones align, and then you can test yourself, as Hein said, by just looking at the X-rays. So you can improve your ultrasound skills in a very low risk environment there. Thank you.
Okay. Yeah, so I agree. Red Cross Trauma is fantastic for lots of learning there. Regarding the ulnar deviation and palm reflection to get to this sort of position, to put the hand in, that's opposite to the way the collies is broken. So to give you sort of some other sort of supportive evidence that we shouldn't be doing it in this position, but perhaps more of a functional position. Look, I actually can't give you any formal evidence on that front, and perhaps someone else can, or feed into that, whoever's on. However, one thing I do find is, if you're going to be putting into this position, it's also just remember all of this is a dynamic process. And one thing I think it's important in this health advocacy to the patient, which we often don't do well enough, or maybe even in the orthopedic clinic, is once they've come out of this backstab support, to see what sort of position to also put it in from a longer term point of view, but then also ensuring that they get adequate therapy or physiotherapy afterwards and utilizing that well. Often left to their own devices and may not and achieve a good outcome because of that. And you can also help facilitate that. It's one of the things I tell all the patients. I said, look, you know, the surgeons may have a knife, but one of the things you can just sort of help discern one surgeon from a better surgeon, perhaps, is also their team that surrounds them, and the influence that team has on providing overall care for that patient. And that, I think, is important. And you can also help facilitate that and tell the patient if they aren't getting that therapy that they need, then they need to ask. And demand more from their the orthopod or whoever is actually going to be providing care. But you're right. I think those the problems are there. I think that sort of, I can't give you the evidence, and as I said, somewhere whether anyone else may, for any sort of neural impingement or neuropathy or tendinopathy or problems that may occur because they're not achieving some functional result early on. Yeah, I don't know if that helps, Camden, but one thing I do know is so just from a personal experience, so I broke my triquetral fracture, which is the second most fractured carpal bone that you can achieve. And we saw the pooping duck sign on the actual lateral x-ray after quite a few different views, but I got that. One thing that I did go is I went to the occupational therapist, and I still actually can't get as full extensive flexion or extension on my wrist, but they put on a dynamic cast on my wrist here, and that was really, really useful. And seeing the occupational therapist regularly to help achieve sort of a better outcome and a grip strength that is reasonable. And I think that's important, advising that. But there are many different modalities that you can use if you break your wrist or your bone here. It's not just plaster. As I said, OTs with their molded dynamic splints that you can take on and off, etc. Be an advocate for your patient, and you are now reaching a stage in your career where you can be a serious advocate for your patient and not just be a casualty of the system as well. So, for example, we had exactly this, a patient who did injure one part of their wrist. I can't remember exactly, but I picked up the occupational therapist's number, their phone. I walked the patient to the actual unit and got them into the occupational therapy stream right away, because the person does use their hands for their career, and that worked really well. So so that's the other sort of pearl or tip, I guess. Be an advocate for your patient, and so you can achieve a good outcome.
Thanks, Eb.
Anyone else? I'm still learning on this IT side. Cornell, how's it?
Good, and you?
Good.
I'd just like to add, maybe just empowering your patient as well early on. Patients with the wrist fractures, you can encourage them to use a stress ball at home early so that they maintain the strength. And giving the patient things that they can actually do at home themselves can get them to buy into the rehab, which is a lot of the time what they need afterwards.
So I agree with you 100%. And that starts with you. Starts with you at 2 in the morning, any of us, at any point in time, whenever you have point of contact with the patient. You can make a positive intervention, a difference to their overall success. And think of this, I know it sounds a bit fluffy bunny as well, but from the point of injury, you are facilitating that patient to their point of wellness. And you're just part and parcel of it, but you can really make a big difference. So, and involving the different relative people or staff to help that so that they overall achieve a good outcome. Yeah, but that's exactly it. So using a stress ball, even doing other activities with Also really like those, tensor bandages, those stretchy things, so the different color ones. So I've used them myself. So I hit a tree when I was skiing when I was younger. This was in Canada, and dislocated my shoulder and separated it. And then I ended up having to use these sort of green, yellow, red, different stretchy bands, those stretchy band things, and they work really well. So you can take them anywhere, wherever you go, and they work really well as well. So that's just an idea, another dynamic sort of stuff that you can do. But yeah, again, be the advocate for your patient. And thanks. Good. Anyone else? I don't know.
Dave,
Fine.
Kitty, I saw. Is it Dave? Yeah, I thought I saw Dave's hand go up.
Dave, maybe he's disappeared. Has he gone? Is he gone to? Where's he gone to? Has he heard maybe he's heard the
there he is.
That
Yeah, there he is.
How's it, Seb? Sorry, man. I was also having technical difficulties, and I couldn't tell if my hand was up or whether it was down. Seb, I just want to check.
Have you been? Sorry, yeah, carry on.
I don't know if Hein's still present. I was just checking. I understand, like, you know, it's kind of new age stuff to be using ultrasound more and more with your fractures and then comparing it before and after. But, you know, if you've got somebody who's got an anterior shoulder dislocation, you're not going to just kind of check and confirm it with the ultrasound and then relocate it and then check your reduction X-ray. Because what if the guy's got an associated fracture or something like that? Because, you know, wouldn't you be running into trouble then? And it's not really defensible.
I can answer that. That's actually not part of your diagnosis, ultrasound. It's actually to assess if your reduction has been successful.
Yeah, but I mean, I presume you're going to be doing an X-ray beforehand?
Yes, definitely. So for your diagnosis, to exclude associated fractures, you definitely do the X-ray beforehand, because unfortunately, especially in our setup, that's the only way we can archive our findings. But the ultrasound is only there to guide your procedure, to make certain that you don't waste time by sending a patient with a failed reduction to X-rays. Okay. And especially for your obese patients who has more flesh on the bones that you can't really see if it's been reduced properly or not. And the same applies for fractures. Does that answer?
Yes, it does. Thanks very much. Thanks a lot.
Brilliant. So,
hi, and I'm going to raise my hand to that one as well. Just your ultrasound guidance tips on that front. Is there a good site or good sort of info that, well, myself as well as any of the registrars or anyone listening who would like to read up more about it? Or
yes, there are. The problems. There are too many. So what I would do is I would sieve out the proper ones and I'll post it on the forum.
Okay, super. Okay. Thank you.
Brilliant. So.
Great. Is there anyone else, or is it Dave? You're raising your hand again? Nope. Okay.
Yeah. Sorry about that. Bad.
No problem. Cool. Well, thanks very much, everyone. Yeah, it's a bit of a trial and error. Definitely need a bit of tweaking if I'm going to be offering any sort of other further teaching. But yeah, this is and maybe also you've taken some aspects from what I did that you can perhaps utilize. But I think definitely does take a little bit of practice on the choreography side to make this an achievable sort of setup to convey information to you. But as I said, I'm going to be doing also the videos to augment and supplement what I've done. And yeah, I hope at least you've managed to gain something from already some pearls or tips that I can offer on a practical level. So, you know, offering practical solutions for impractical problems for the patients.
Thank you so much, Seb. This was really very useful. I know you were very nervous about the technical aspects, but it has actually worked out quite well. And thank you for piloting this practical approach using Teams. We will definitely invest in it for the future. Thank you so much for a great talk. We will add the additional resources and Life in the Fast Lane links Lauren have already added. And then we will add your video once it's available.
Fine.
Thank you so much.
Okay, great. And then, so I'm going to do the other talk aspect on back pain. What I'll do, you can have a break if you want, go to the loo, get something to drink or anything like that. And then I don't know what time you want to say, in 5 minutes to go through back pain.
Seb, how long is your presentation?
It's not very long.
Then I would say probably with Teams, awkward to have people indicate when they're back from the loo. So I would say, given that it is recorded, maybe just let's carry on.
Okay. Yeah, that's fine. Don't worry, I don't need to go to the loo either, so it's okay.
Okay, excellent. That's good to know.
Fine. Then let me just figure out this IT side to get that other talk up. Okay. So bear with me for a moment. Sorry about this. And whoops. Where are we? Okay. So the other topic that Jeannie McCall mentioned, the orthopedic surgeon, saying just our understanding of back pain, and so she said basically also the main red flags of back pain, and just go through that very quickly with you. And back pain's an interesting one because there are a couple of key main things with back pain. So is it mechanical or sort of more neurological aspect to it? And then there are lots of other aspects besides the key structures of the back that can give rise to back pain, and you need to be aware of them. So in your practice. And one of the important things with back pain is I've found over the years and even recently is there quite a varied interpretation of what people consider badness of the back, if you will, to put it very simply, and how it's managed, and whether you speak to an orthopedic surgeon or a neurosurgeon, and you may get two varying opinions on when someone may actually operate or not. And I think that's important to bear that in mind. And I think this goes back to my previous advice to you is advocate for your patient. So you're not going to be phoning the radiologist or a person on call and be ordering an MRI for every patient. I mean, obviously we know that, and that's just silly. But if you do worry about the patient, that you think that there's something more sinister or serious, you also have to think, well, if it was me, or not even that, but I want to achieve a good outcome for this person, then advocate to that person. You really do work hard to achieve the best outcome for that person. And that's, I think, important. And don't ever let go of that in your career. I'm fortunate. I work at Victoria Hospital. I have a very strong and good relationship with the radiologist and all the specialists here, actually, for that matter. And I am fortunate that I can pick up the phone and order a CT scan within the next few minutes for a patient that I see. That doesn't mean that I need to abuse that relationship or order things willy-nilly that also have a potential harm for the patient. But it does allow an opportunity to do things and get things done for the patient to achieve a positive outcome for that patient, in my opinion. So often we've all encountered problems like and resistance for certain aspects of wanting to order extra or advanced imaging for a patient, and that's a challenge. A challenge that's not overcome, that we cannot overcome, but it is a challenge at times, nonetheless. So just to remind you of the anatomy of the back.
this lumbar spine, spinous process, disc, vertebral spinal root, etc. A lot of this I'm going to fly through very quickly, and the reason is I want to just give some pearls with back pain that are very, very perhaps you can take home with and utilize in your daily practice, because you see this regularly. Perhaps even on every shift, you'll come across a patient with back pain. And for example, the case I'm going to go through, we had fairly recently, very recently, in fact, it's something that I encounter perhaps more regularly than I'd like, in that the patient often sees someone in the emergency unit, initially gets assessed, gets discharged, and then weeks or months later returns with worsening symptoms and signs. And that's hopefully we can maybe mitigate a bit better if we know what we're dealing with. This I put up just for anatomical picture. I like pictures visually that make sense to me a lot in my practice and in my mind, eye, and mentally. But this is also important to know why this may impact on your signs that you see and when you examine the patient. So more commonly, the disc herniation happens at L4-5 or L5-S1. And as you can see, the disc herniation with the nucleus pulposus or and rupture of that annulus, if it's more medial, and hold on, let me just get this laser pointer. So more medial, and then impinging on the L5 nerve root that's coming from the vertebral body above. As we know, that's what happens in the with the chorda equina. And I'm not talking about the chorda equina syndrome, but the chorda equina, the lower part of the cord. And then or more lateral, and if it pinges more laterally, then it's impinging on, you can see the different nerve root that gets impacted, which will then impact on your examination or the symptoms and the signs, the symptoms that the patient presents with, and then the signs that you elicit when you examine the patient. This is important, and for you also to be a good clinician. So lumbar radiculopathy, so S1. Okay, extending all the way down the lateral part of the foot, and the motor test that you will do is also checking, can the patient walk tippy toes or plantar flexion on their feet, and if they can't on the one side, then that's a clue that the S1 motor motor nerve root is impacted, and then also the sensory deficit on that side, as you can see here displayed, when you're looking for any sensory deficit as well. Okay, L5, what is L5? L5 is dorsiflexion of the big toe and of the foot. So if you ask the patient to walk on their heels clinically, and they cannot do that, they cannot lift their toes up and walk on their heels, this is just a good little tip for you to utilize. Then you, it helps point towards a L5 motor neuropathy, and also then obviously the associated sensory deficit there. L4, as you can see here as well, and also knee flexion extension. And L3, also for knee or hip flexion, sorry, here, and the neuropathy coming down and the sensory level deficit in the mid part of the thigh. Okay, so this is just to give you some, the reason I'm pointing that out to you is because I want to take this further when I present the case to you. Okay, so red flags, what are the red flags? Depends on different sites that you go to. This is from Prof. Robert Dunn, who is the orthopedic spinal surgeon at Curtis Skier, and these are his advice of red flags that we need to be aware of. Okay, and the reason I've also put highlighted in red is red, and I mentioned it earlier. Are red flags as red as they need to be, or should we be worried about the redness of them? And I think, yes, we do, but if the redness is not there, just to put it very simply and kind of make it a little bit sort of more play on words to remember, but if your red flags are not red or they're not there, it doesn't mean that you should not be worried that your patient may not have something significant. So please, as I said, if you're worried and your clinical gestalt says this could be something more serious and you're not sure,
then don't dismiss it. Okay. So age is one of the red flags. Okay, so I'm going to remember this because we're going to go to the case. So age, less than 20, above 55. There's a general guide, a rule of thumb. Obviously, it's not fixed in stone. You know, if you have someone a little bit younger or a little bit slightly older or a little bit in between there, that they may or may not have other aspects that are important. But the reason age is because also their young age, and if they have any congenital abnormalities, then that also will help guide you. And obviously, the older the person, the more at risk they are for other comorbidities and problems, and also their bone density may not be as good as it should be, increasing the risk for potential traumatic fractures as well. So, which goes to the next red flag, which is trauma, a severe traumatic fall from a height, down some stairs, or a motor vehicle accident, for example, which then they sustain, let's say, a chance fracture or a lumbar spine wedge fracture, and with perhaps even the more severe or the kinetic energy, the more the potential that vertebral body can actually rupture and become comminuted, and pieces then can fall away from that. Like a Formula One car breaking up into pieces, that little piece that may have broken posteriorly into the vertebral column itself and then impinging on the spinal column. Not the vertebral column, but the spinal column, sorry. Then the other red flag is pain. So this is important, and I think this is it's often one that we sometimes sort of, look, it seems that the pain is constant. Is it progressive? Is it unremitting? But don't dismiss this with your questioning. And you may need to even ask a number of different questions from different angles to get an idea that this is maybe a non-mechanical, unremitting, progressive, constant pain that just doesn't want to go away. And that's important. What about neoplasm cancer? Why is this important? Because, as we know, many cancers spread to bone, and they result in then obviously the integrity of that bone to become compromised, and you may get some fractures, or even and then also locally spread into different spaces, for example, the spinal column itself. And one thing, just as a tip, if you're trying to remember anything, I was taught this years ago, and I thought it was a quick way of remembering it, is the law degree, I think it's sort of, I don't know if it's, is LLBA, right? So lung, liver, bone, breast, and adrenals, spreading to each other, if you will, spreading to, so that's just something to, as a quick sort of remembrance for cancer spread. Okay. What else? Then being immunosuppressed. This is, so a person on steroids, bit self-explanatory there. I'm not going to spend too much time. Person who's retrovirally positive as well. And the reason that is important is also think of those patients that you may have seen who you were worried about an epidural abscess. And the person who is an IV drug user, also that person who you worried about could have an epidural abscess or a complication on that front because of their intravenous drug use. Pretty less common in South Africa, but we had quite a lot of patients in the UK or in the inner city hospital I was working in Bristol. And it wasn't an uncommon differential, or in your differential, if a person came in with back pain and they had this sort of social history, you needed to think about it. If you don't think about it, you're not going to then look for it, and you're not going to investigate for it. And the investigation for this is quite an important one. It requires a full MRI from neck, from the cervical aspect all the way down to sacral. Because remember, they may have skip lesions as well, and this is something you may miss if you just have a focused scan in a different area, in one area. What happens if a person's systemically unwell? So they have a fever, headache, how are we doing time-wise? Sorry. Fever, headache, and night sweats. So this is important, probably the most important part of the whole talk on back pain. So is this whole red flags, and that's what Jeannie wanted us to know. But fever, headache, night sweats, any sort of systemic generally complaints that the person may have. However, if they don't have this, doesn't mean that they may not have something brewing, and you need to also have a high index of suspicion for this, for a potential more serious problem in the back. Okay, and then neurological signs. So Robert Dunn mentions widespread neurological signs and symptoms. So they have bladder, bowel, saddle anesthesia, lower limb neurology, especially if it's bilateral. And this is important. So that if they have cauda equina, you must know that they need to have the anesthesia, saddle anesthesia, with any bladder or bowel symptoms as well. And they may have overflow incontinence. Normally it's urinary retention, but they may have overflow incontinence as well, and bowel incontinence as well. Okay, so one thing I did give a talk to you guys, or may not all of you may not have been there, but about weakness and localizing the areas of weakness. So one thing with spinal cord problems is the weakness. You won't have, you generally should be from the area of where the lesion is, and if your weakness is typically with a cord lesion, if it's like maybe bilateral, but it's not normally going to be totally symmetrical. So you're going to have a bit of variability between the left and the right. Going to slightly decrease power on the right versus the left. Both may be decreased, but it's not going to be totally equal. And that's typical of a lower motor neuron lesion, okay, in this area. And same with the sensory deficits as well, okay. And then restriction of movement, persisting severe restriction of lumbar flexion as well. That's maybe part of your red flags. Not all sites include this as a red flag. The main ones are above. Loss of weight is another one, for particularly pointing towards neoplasm, or the link with neoplasm as well. Okay, so this is a patient that actually we just saw a few days ago. As I said, it's a common complaint and something you're going to be seeing regularly, and this is what we saw. So person came in, he's a 72-year-old male patient. He has a past medical history of hypertension, and he has a previous EC visit for low back pain about 6 months prior. Okay, so the reason I put that in there is bear that in mind. This happens commonly and often, that we see a patient with back pain and we think, well, they don't have cauda equina, so, or symptoms and signs of that, so we send them home for conservative management, and some of them come back with further deterioration and problems. No history of cancer with this patient. Important why I'm mentioning that, because on the clinical side, it didn't look like that. And then no steroid or IV, no steroid drug use. And he's an ex-smoker, also important with that, possibly with cancer, and no IV drug use. Okay, I know he's 72-year-old male, but please do not forget to ask these important social questions for your patient. Okay, so whether you're IV drug use, illicit drug use, or as in a modern era, any other questions that may be socially sensitive, but they're important for you to ask, which you may be surprised what you may find or hear. So his presenting complaint this time, he's had back pain for a few months, thought this would go away, not relieved by any particular position. So that's important, a red flag, right? So what are the other red flags that I want you to pick up here? So also progressive lower limb weakness. That's over the last month, with the left leg being weaker than the right. Okay, so neurological signs, widespread neurological signs and symptoms, with lower limb neurology, especially bilateral. Okay, he doesn't have cancer. However, if you go back to the presenting complaint, I don't think I have it here. I have it on the next slide. He's cachectic and wasted. There is a history of increased difficulty passing urine and stool. So that's another red flag. Okay, so he's now got a couple of red flags here, there. constant progressive unremitting pain. He's also got a red flag here. That's his age is a red flag. Pain is a red flag. Is no real systemically unwell. Neurological signs is a red flag. So 1, 2, 3. Restriction of movements is a red flag. That's 4, and weight loss is another red flag. Although he doesn't really mention that, but you can see he's very wasted and cachectic. History of increasing difficulty passing urine and stool more recently, especially after taking tramadol, and no history of trauma. So he's got a number of red flags. So what do you do about it? So on examination, you look, feel, and move, just as what we taught all the time. But this is important. How are we doing time-wise? Okay, not too bad, I think. So on inspection, no evidence of obvious abnormalities when you just look at his back. Okay, and I'm just talking about the back here. The way he's lying in the bed, though, when I saw him, he wasn't looking like he was in a very comfortable position. Okay. Palpation, no step, mild tenderness to palpation and percussion. So one thing I want to ask you, whenever you examine the back, and this also goes for the trauma patients, do you percuss the back? If you don't, I highly recommend you start doing it. It's a little sort of increased sensitivity to maybe delineating potential pathology that you may not find just with palpation. And I find sometimes with palpation is also not that great, because anytime you push on a bony point, some people will find it sore, just like you push on like sort of C71 in the cervical spine area, and you may get elicit response, but it may not necessarily be what you want you to achieve. So I percuss the thoracic lumbar spine quite regularly to achieve if it at least elicits any response, particularly pain or discomfort with the patient, which may help transmit any force and vectors across the spinous process, the lamina, the pedicles, and to the vertebral body. Okay. The other thing is, what is the skin looking like? So is there sort of a swelling there? Is it warm? Is it red and erythematous? Also pointing towards potentially any soft tissue inflammatory response that's going on. Limited movement due to pain. So this patient did have limited movement due to the pain. And this is another important test, and I put it in here for you to also look at and read up on, is the cross leg raise. It was difficult to perform in this patient, but the reason I wanted to do it was also just to see, would this help increase my specificity of this eliciting any pain that may be going from the leg, or from the back, sorry, down into the leg, particularly a radiculopathy. Okay. For sciatica, this is shown to be, this test, the cross leg raise, has been shown to increase your likelihood ratio that this is a sciatica, maybe going from sort of a likelihood ratio of 3 to just over 4, which would be like a straight leg raise would be your other initial test you would do, and you do a cross leg raise and shown that this is increasing your specificity. So please use it in your armamentarium in a way of when you're examining patients with low back pain. Neurology. So this patient had neurology. So this is also one of the red flags. Okay. So his neurology was decreased power with hip flexion. So if you can think back what I posted earlier, just in the last couple of slides, what is the motor nerve root for this? Okay, and adduction of the thigh. He had a decreased movement of that area. Okay, and the right was worse than the left, fitting with the lower motor neuron back lesion. And we need to locate the lesion, or at least sort of identify, or at least have a presumptive sort of area that we think is abnormal. So this hip flexion adduction of the thigh, I'm going to mention it to you, but hopefully you've thought about it. Try to actively recall in your mind what this area is, and it's L2, L3, okay, sort of in that area. Normal anal tone, that's important for also potential saddle and cauda equina, which he didn't have features of, or any saddle anesthesia or perineal anesthesia there. Not able to perform a standing on heel or standing on toes test, and I just mentioned that I tried, but I didn't manage to. The reason is I was just looking for a lesion somewhere else or lower down the spinal cord. So standing on heel, remember, as you recall, a nice one to do in the unit. It's very quick and easy, but it'll help you delineate if the guy or person, sorry, cannot dorsiflect the toe or foot properly, then that's likely an L5 lesion. Or they have this foot drag, you know, it's dragging on. So then if they cannot stand on their toes, that's S1. Okay, so, and that's just another area or way of delineating where you may suspect the lesion may be. Sensory deficit decreased, especially in the right and the left, to approximately mid-thigh. So is this what we're expecting? Yes, it is, because it fits the motor neuve root area as well, and mid-thigh fits sort of an L3 sensory deficit neuropathy there. No perineal or saddle anesthesia, as I said, so motor, sensory, and reflexes. So why are reflexes important? They also help to delineate, looking for any lower motor neuron lesion and upper motor neuron. So as I said, you know, you person with back pain and limb weakness, know where is this coming from? And I mentioned it in, as I said in a previous talk, that you're going to be wanting to now identify, is this coming from the cortex, is it coming from the midbrain, is it coming from the spine, is it coming from the neuromuscular junction or from the muscle belly, right? Okay, so generally he's wasted and cachectic, and the reason I mentioned that is, as I said, on the differential problem list is, could this be a non-benign lesion or a cancer? Rest of the review of systems was relatively unremarkable. And so what are we going to do for this guy? Okay, so the management plan. Okay, we're coming up to the end relatively here. I hope this is okay and it's not too late for you. The diagnosis. Is this mechanical or axial back pain versus nerve compression? So I want you to think about it for a while. So this person, it seems like he may have a bit of both. He's got some back pain without any good ability to flex or move the spine properly. And he's also got so axial back pain. So there's actual structural pain or a back problem or a spinal problem. And then he's got some nerve compression that it looks like that you may think the person's got from based on your examination. So this guy's got some badness in the back with some neuropathy further inferiorly, and we need to help him. So this goes to my recent examinations or a test or FCAM that I did when I was studying, and I like this, and I'll share it with you as well. Another mnemonic, I know, but I found this useful. As I said, I had spotlight paralysis during my exams. So trying to unlock the brain to alleviate the spotlight paralysis. So I bill the patient if I do part of my management plan. And what do you mean by bill? Well, bill as in, actually that doesn't come up there. So let me, so bill, BIL, bedside tests. So what are the bedside tests we can do for this patient? So urine tests as well is one, and it's a simple poor man's CVP in my opinion. Some of those are poor man's tests. The other bedside test is ultrasonography, and that's important, and I'll tell you why just in a minute. ECG as well is also important, and then so those are the bedside tests, etc., that we can do. Urine dipstick prognosticon, obviously if this is a female patient as well, it's important that you want to know what's going on there. Imaging, so BIL, so imaging, you can put POCUS under imaging if you want, or you can put plain films and then you can put advanced imaging. So as we know with the red flags and back pain, what is the benefit of doing plain film x-rays? Well, for most patients who have back pain, the imaging use of x-rays is not great, the yield for that. But in our setting, I think it's important to bear that in mind. Our burden of disease with TB and tuberculosis is high. It's a useful, simple test, and we have it relatively available. So I would still recommend doing it. However, in the patient that you do suspect that there could be something more sinister going on, it is at your discretion, but I would support it that you can actually skip over doing a plain film x-ray and move straight on to trying to request MRI if you can, or if that's not as easy available, like for us, CT was more readily available, so to move to a CT scan. So, and then labs. So why are labs important? Labs are important particularly when you're thinking, could this be a potential epidural or abscess? In that sense, for example, and you're needing to help with the clues to this puzzle. So doing a CRP that's more than 20, or sorry, in ESR, a raised CRP as well, which, you know, we know these tests are not absolutely the best sensitive and specific markers, but they're still clues to a puzzle. And that's what this is. So, and one of the things of doing that test also helps with your argument when you're going to be talking to the orthopod or neurosurgeon and saying, look, I've got this patient, I am worried about this, they've got these sort of symptoms and signs, and these are some of the tests that have come back that are positive, and I'm worried. And you document in your notes, please, from that you're worried and you want to refer the patient for further imaging or for further assessment, if that's how your system works, that you refer to these specializations first before you order any imaging, and then they go on to take it further. That's okay, depending on your system and how robust it is and how it works, but that's okay. But you've still, at least when you've advocating for your patient that you worried that this could be something more sinister. And it's one of those ones that if you're not thinking about it, you'll miss it. So as I said, with regards to POCUS and point of care ultrasound, why is that important? Well, just as another thing to remember with back pain is, could this be something else? So easy to do. Put the probe on the patient and look for AAA, okay? Or look for any other lesion potentially. And one of them that I've noticed when in my unit or practice here is I try and encourage the use of ultrasound for every patient, and we can put it on the liver, and we see multiple heterogeneous, irregularly circumscribed lesions in the liver. And what does that tell you? Well, this could be something more sinister like a neoplasm. And then you're thinking, well, this could be also then maybe he's had neoplastic spread to or elsewhere in the body, like the spine. Sorry. Then going on to treatment modalities, well, analgesia, conservative therapy, rest is part of your therapy, but always important that in the past we used to tell patients, you know, lie still, lie on your back, but that's not the case anymore. We obviously advocate again for the patient to say, look, move within your tolerance level, but do not go and just lie down and be still. Your body is designed to move. So do move within that tolerance level, take your analgesia, encourage that, really stress upon the patient that if they do that well, they move a little bit every hour, each day. They will and should get better. The majority of your patients will. So over 90% of your patients will get better within the 4 weeks. There's only a few minority or percentage of patients that will go on to have something else more serious, and those were sort of the red flags before to help delineate that. But also using your own clinical impression too. But you know, in the end of the day, less than 1% of patients actually only get surgery actually. So even patients who may have some cord impingement will still, your approach to that could be conservative therapy like analgesia and rest, and then core strengthening exercises like good physio and exercises in that way. You know, as our patient population becomes more sedentary and people become more their muscular support structures around the spine become weaker, then you know this is a certain concern that it's a rectifiable problem actually. So we need to encourage patients to do a better job of that. Disposition, as I said, this could be home, which most of our patients will be disposed of home, but then and using this mnemonic again, HOME, so health advocacy, outpatient follow-up, medications, and explain to patient when they should come back. And explaining to patients that when they should be coming back is, are they able to urinate? Are they able to defecate? Is there a problem there? Have they got increasing neurology with pain and numbness and decreased range of motion and function of their lower limbs as maybe this progresses. So initially you see the patient, he lifted something, let's say on a Saturday, because he's moving some sort of item at home and complained of back pain, and then progressively that gets worse and worse and worse. So, but in this case, in this patient, we've already identified quite a number of red flags, so we want to investigate further. So what we did is I actually phoned the radiologist and said, look, I'm worried about this patient and I'm worried that there may be a lesion in the L2, L3 area. So he said, fine, let's warm up the CT and let's fire the patient through. So as I said, there's the home mnemonic again to just advocate for your patient and how you're going to manage the disposition of that patient. So, but before we get there, I just want you to bear in mind, red flags for lower back pain are not always really red. Okay, so that's important. And when you go through this screening question for lower back pain and you've gone through all of them and you think, oh, well, that's done and dusted like a tick box. That's not how you should be approaching this. You should be approaching it with element of potential that could you be missing something and be well, just to be advocating for that patient again, that hold on, I'm concerned that maybe the patient doesn't have a red flag that's as easily delineated, but you're still worried that there could be something more sinister. And the results of that study did here, and I just want you to bear in mind, for patients with no recent history of infection or fever, chills or sweating, the presence of night pain was a false positive for finding infection, greater than 96% of the time. That's quite a lot. In general, the absence of red flag responses did not meaningfully decrease the likelihood of a red flag diagnosis. Okay, so if it's not there and you're still worried, then that's then keep being worried. Okay. And try and either get some further imaging or if not just imaging, but actually refer to the appropriate specialty, whether it's neurosurgery or orthopedics in your stream, to make sure that this person gets assessed appropriately. And this is the other thing that I want you to advocate in a system where juniors are often working and you're worried. So not to undermine anyone, but if you're referring to a specialty and you're concerned and you think, oh, they're going to get the best care, then also involve all the people involved in that other referral specialty. So like if you're referring to, an orthopedic person who's an intern, maybe you also want to say, look, I think I'm going to have a conversation with the orthopedic specialist as well. Not to undermine that person who you're referring to, but also just to ensure that you're wanting to get the best outcome for that patient. Okay. So what do we see on CT for this patient? So red flags, as I said, there were about 5, at least 4 to 5 red flags that we picked up with this patient. Okay, and we can remember those red flags again. Okay, so and here you can see if you count up 5, 4, 3, 2. Okay, so 5, 4, 3, 2. So L2, L3, and what do you notice? The intervertebral disc space here is narrowed. Okay, so which fits in keeping with that. Maybe there's a disc lesion, and this area which fits with the neurology that we picked up on the patient. Okay. The other thing that you then see when you do L5, 4, 3, 2, 3, and 2, is the cortex is not completely crisp here, and a bright area here with looks like a calcification extending posteriorly into the spinal canal. Okay, all fits in keeping with what we found. Again, here's the lesion here. Patient's old, so spinal stenosis and ligamentum flavum that becomes a bit thickened and hardened, and disc hardening that was noted also on CT for this patient who had back pain. Patient was referred to orthopedics for further ongoing assessment and workup, and also just deciding what kind of management plan should this patient have, whether it's conservative or is there any other surgical intervention that may be appropriate for that patient. Remember, not everyone needs it or is a good candidate for a surgery, or should they even get it, or not necessarily get it, but good shared decision-making process that will result in a better outcome for that patient. And that's it on my side. Hello? Anyone? Anyone?
Thank
5
you,
to 4. I
Seb.
hope that wasn't too long. Sorry about that.
No problem. Thank you, Seb. Are there any questions? Dr. de Haan at this point? You can just raise your hand. Use the chat.
So red flags, please know them, or at least so when you're standing there and going through. Yeah, those are something that the orthopedic surgeon mentioned, but also I think it's important for us. One of the things, you know, in ATLS we learn sort of sensory nerve roots and motor nerve roots. It's not without importance. So, you know, the more you sort of remind yourself of some of those, the easier it is to remember. And you know, look at your phone Dr. Google's in your pocket to remind you of what those are. But it'll help also so that you can actually localize the lesion initially clinically, which then you can correlate it with your other investigations as well. Anyone else? Any other questions, or no? Have I bored you to death? You're falling asleep. Is that it? Okay.
No chance for you to bore us, unfortunately. This is a very important topic. Thank you so much for the teaching that you've given us on back pain and especially the danger signs. Thank you also for giving us another perspective on the approach and being an advocate for your patient. I think that is something that, especially in busy units, that we tend to overlook again. Just a special thanks also to Prof. Haan for his input. It helps a lot. I don't think there are any questions at this point, Seb, but I really want to thank you especially for taking the time and the effort. We appreciate it.
It's yeah, a pleasure, and thanks for also inviting us and involving us. Yeah, these opportunities are always good, and yeah, they're great for us as well to have constant exposure to the academic side, which is a very important part of our specialty and just in our career. So yeah, I enjoyed it. Thank you, and yeah, yeah, to this. Practical teaching in a virtual environment is something I'll just definitely need to think improve on. Whether we use any virtual glasses and things like that is another opportunity, I guess, to explore. But yeah, I will be sharing with you the videos, and that will come in due course. Good luck, everyone, as well for your shifts. Advocate for your patient, as I said. And yeah, that's it.
Thank you, Seb. Thanks everyone for joining.
All right, thank you.